morning, everyone. Bonjour, buenos dias, bon dia. Barka Kudakwana. Jumbo. My name is Frank Conlon. I'm the director of the core group Polio project. And you all are a very diverse group. But you're all here because in one way or another, your work endeavors to reach every child and provide for their health needs. We in polio eradication share that goal, and we've been working at it. The one most dramatic number is that about 30 years ago, when the World Health Assembly declared the goal of polio eradication for the world, there were 350,000 new cases of polio that year. That's about 1,000 new cases a day. This year, to date, there have been 10 new cases. So we're very close to interrupting the transmission of this virus. We're not finished, and it becomes increasingly difficult to reach the last child and reach every child. But what we want to do today is help you understand how we evolved this very successful program for polio eradication, and let you be the judge, not of how well we have done in polio work, but judge whether there's any realistic application for the work you do going forward. To help do that, we want to tell stories. You may have noticed that there are no projection screens in the room. In our time together, we won't be using any PowerPoints. From our side, we have invited our in-country directors, our Secretariat, you'll hear more about that, our Secretariat directors from India, Ethiopia, South Sudan, Nigeria, and the combined Kenya-Somalia Secretariat. They have a lot of experience, and they have stories to tell. And we're hoping that through a combination of panel discussions, questions from the floor, small group discussions, that by the end of the day, which is about 4 hours from now, we will have done the best we can to tell our story and let you be the judge. So, I remember a long time ago when I was a little younger, a colleague of mine said that his mother, who was apparently very wise, what mother is not, she said, you must stand up to be seen. You must speak up to be heard. And you must shut up to be appreciated. So that's what I'm doing. I want to hand over to Nellie Bristol the microphone, and she will be moderating our first panel. Nellie, as you may know, is a senior fellow at the Global Health Policy Center, situated at the Center for Strategic and International Studies. And her focus now is basically on the types of things I just mentioned, on looking at the realistic possibilities of transferring polio infrastructure, personnel, and knowledge to other public health priorities. She's visited many countries, including, well, Nepal, Ethiopia, and India. Nepal was one of our original countries almost 20 years ago now. You'll hear more about this, and I promised to shut up, so I will do that. Nellie, please take over.
Thank you, and good morning. So we're here to learn about one of the aspects of polio transition and sort of beginning to look at this infrastructure and see how it can be applied to other health activities. And we have a great panel here to help us out. I've had the privilege of working with all of these people. And I'll just do a brief introduction, and then we'll get to the questions. And then after they talk for a while, we'll open it up to the audience for question and answer. So we have Dr. Philemona Bizrat. He has worked with the health and humanitarian organizations, including the Ethiopian Ministry of Health, Administration for Refugees and Returnees Affairs, and non-governmental organizations for 29 years. Since 2002, he's been the Secretariat Director of the Core Group Polio Project in Ethiopia and a Senior Regional Advisor. I'm just going to give a brief bio here, so you can look them up online, I'm sure, but just to move things along. And then we have Ellen Ogden, who has the greatest title ever, the Worldwide Polio Eradication Coordinator, and she's a Technical Director at the U.S. Agency for International Development, and a Senior Technical Advisor for Health and Child Survival since 1997. And she's responsible for USAID's $59 million annual polio eradication budget and works in over 25 countries. So, Ellen. Lee Losey has more than 25 years of experience working in international health and development, starting as a Peace Corps volunteer to Tanzania and working for CDC, WHO, CRS, Save the Children, CARE, International Mercy Corps, and the Chicago Department of Health and the University of Illinois, Chicago. And Ambassador John Lang is a senior fellow for global health diplomacy at the United Nations Foundation and serves as the foundation's primary focal point for global health diplomacy activities and its wide-ranging work with the World Health Organization. So welcome to you all. We're going to launch right into these questions and get this conversation going. Ellen, for the benefit of those who may not be familiar with the Core Group Polio Project, could you give the audience a short history of the project's scope and accomplishments?
Sure, thank you, and thanks to everybody for being here and for PATH for hosting. This is really great. The Core Group Polio Project started as an idea. Back in 1997, when I first took over the polio eradication program, it became clear to me that the UN agencies were doing a good job in getting up and started, but that they didn't necessarily have the reach into communities across the world. And the original polio eradication strategies were developed in the Americas, which didn't really need that much community engagement. But knowing development, knowing aid, knowing these countries we were working in, it became clear to me that we needed to have a structure to reach down to the lowest levels of the community. And for those on the phone, if you could mute your lines, that would be great. Thank you. So the purpose of this really was to harness networks of NGOs in polio priority countries to assist in areas that go beyond the reach of governments and UN agencies. The activities we envisioned even way back then included community mobilization, community surveillance, improved partnerships and bringing that voice from the community up, and what were really the barriers to immunization, what were the obstacles. And to do that, we needed to build on the in-country presence of existing NGOs. So everything we did in this program is built on a long history of NGOs being in these countries, having established trust, knowing their areas. And with a little bit of extra money, we allowed them to focus on polio. But what we've accomplished is much larger than that. I think there's, after 15 years of consistent engagement at the community level, there is an unprecedented level of trust. And we have overcome resistance. We've opened doors. We now have systems for newborn and child tracking. We have democratic discussions with local leaders and holding them accountable. We are the epitome of equity. This program reaches the doorstep of every child in the developing world. And the ones that are hardest to reach, the most left out, the most marginalized, those on the borders, in settlements that are very hard to reach, that's what this project does, and that's where they focus. So when you think of equity and reaching the fifth child, the core group polio project has really figured out how to do that consistently, repeatedly throughout many years. So it's gone to scale, and it's not these are not pilot projects, they're demonstrated, highly successful programs in difficult areas. And in many ways, the program gives, it gives voice to the higher levels of government about what is happening in their community, what's the effect of these national programs, and how we can work together to solve some of the most intractable problems facing governments and national programs today. Thank you.
And so Lee, can you talk about what the Secretariat model is and how, and this is, I'm adding on to this question because this is something I've been curious about, how does it differ from the way NGOs work normally?
Okay, thank you very much. I might even stand up if that's okay. I was a teacher at one time and I still feel comfortable. And I noticed we're not on a higher panel, so people in the back can see easily. One of the key parts of this project has always been this Secretariat model, and there's maybe a few components to that, and it's all about working in collaboration and coordination with multiple partners. I often say that we are a coalition within a coalition. Members here today, such as UNICEF, who are part of the Global Polio Eradication Initiative, which is the initiative, the coalition that has been successfully behind polio eradication since its initiation in the early days of 1988. So the Core Group Polio Project has partnered within that coalition. And the way we do it in each country is we have a secretariat, which is a small team that is set up in that country to coordinate the work of all of the NGO partners who are working on this project in that particular country. And there's a Secretariat director who sits on usually an interagency coordinating committee, or these days we have something they call an EOC, that is an emergency operations center, but are there present to participate in national level meetings where the discussions and coordination of routine immunization and polio eradication are taking place. So by sitting in that group, that gives the NGOs a voice. And in terms of implementation, I'm not going to say too much about the community level portion because there'll be other people to do that, and the key role of the community health workers. But what I've always seen in the Secretariat model is you've got communication going right up and right down to the lowest possible levels, that is the actual community members. And they're interacting with the community health workers, who are in turn interacting with the project supervisors, who are interacting with the project managers, who have a close connection with the Secretariat, who have a close connection with WHO, Ministry of Health, UNICEF, CDC, and through people like myself and other partners, they are also very much engaged at regional levels, and Africa continent-wide levels, or India level, right up to Geneva and London and Washington, D.C. and New York. So what that does is, I feel like, at the most senior levels, they've got an opportunity to communicate their messages all the way down to the community, and we, through the Secretariat model, have an opportunity to communicate what the community members are saying broadly and high and low. That is, we can share it amongst the other NGOs, amongst the other partners in the country, but we have that ability through that model to share these ideas and get their voice heard at the highest levels of policy making. That is, to me, essentially the crux of the Secretariat model. And that it's not a competitive project, but it's a collaborative coalition project where you get a group of NGOs working together. So you've got Lisa Hilma here, who's the director of the core group. So the whole idea of the core group, I won't say the wrong thing, but essentially is to get NGOs to share best practices and not have to reinvent the wheel every time. So That's why we call ourselves the Polio Project. That we're not trying to work independently or in competition with anybody. We're trying to work together as a coalition, collaboratively to support the polio eradication initiative and communization. Thank you.
Thanks, Lee. Feely, you have some experience adapting the Secretariat model to other health issues. Does the model lend itself well to addressing other issues, and how did you get that to work?
Yes, we managed to get funds. One is for malaria, which is out of the immunization programs, and that was received from global funds. And we received 2 funds, and working the first one is covering around 25 districts. That was a small funds were given the first time, and the second one is covering a large portion of districts. Okay. The second one is covering a large portion of the countries and served for 2 years. That was experienced working with malaria project with global funds. And the second one is we received also from GADI, the project GADI award. That one is also 2 times. The first one is for 3 years, served for 40 districts, and the second one is also now it is under implementation. It is covering 60 districts of hard-to-reach areas and pastoralist areas. That was that we experienced to have another funds from using these Secretariat models. How it is worked, and usually when the request for application is announced, the Secretariat members come together and sit down and explore and discuss, and whether it is working for their project or their areas. Then once it is decided, given the assignment for the Secretariat's office to lead the coordination of the development of the proposal and establish a small working groups, and which is contributed from different partners, technical staffs like a monitoring person, finance person, and the developing of proposal. So different technical persons come together and they started to develop the proposal. And after the development of the proposal, the fund is allocated in the form of transfers. That means every and each organization come together, sit down, and come into consensus. And it is based on the geographical coverage and the localities, infrastructures, and also it is also the population size and also the policies of the organization also included in that part. In addition to that, it is covering also the capacities of the absorption of the funds by each individual organization, because it is a capacity absorption means that we are working not only international NGOs. For example, in Ethiopia we have 6 international and 30 local NGOs. All these are under the Secretariat model, and they are international and local working together without any problems. That is creating another forum to work together to raise the funds. And after that, the Secretariat took places, the monitoring of the projects in technically and financial issues. So that is one of the work modalities that we do. And regarding to the last question, whether it is working with the health and other health projects, and I think the model can be applied for, as I mentioned, it is working with other health models like malaria. It is already experienced, and also we tested one time with other activities as a pilot project with international vaccine institutions, as a pilot project one of the waradas that was working with sanitation and education at the school. So that also is working, So to implement other activities of this model. So I think, well, for other non-health projects, it is depending on the type of the project and the mechanism of the implementation approach that can be working also in other non-health projects.
Great, thanks. And we can get more into some of the nitty-gritty and we break out into the smaller sessions. But so John, you've been involved in polio eradication at various levels for many years, and you are the former chair of the Polio Partners Group. What is your perspective on broadening inclusion and collaboration of partners to polio eradication? And what role do you see NGOs playing in global health issues?
Thank you, Nellie. We heard earlier about the decline in the number of polio cases, and we're very close to eradication. But if you look at the history of the Global Polio Eradication Initiative, it really stagnated during the first decade of this century. And it was in light of that stagnation that the program had a bit of a shakeup. There was the creation of the Independent Monitoring Group, a much more centralized program, control effort on the part of the 5 polio partners with the Polio Oversight Board, the heads of the 5 agencies that run GPI, and then the creation of the Polio Partners Group. And I was the first chair of that and recruited the Canadian ambassador in Geneva to be my co-chair as it began. I was co-chair for 4 years. Some of the people within GPI called it, oh, that's the donors group. And I said, no, that's not the donors group. It's all stakeholders. And in terms of reference, made it very clear that it was all stakeholders. This was not an effort on the part of donors to run everything. In my mind, it was a way to get input from the countries that were affected by polio, as well as the donor governments, as well as NGOs and civil society organizations. And Ellen and Lee both have been very active participants in those Polio Partners Group meetings. The Polio Partners Group was the stakeholder voice and is the stakeholder voice in this effort to keep pushing for improvements. And as a result of the efforts by the Polio Partners Group, and Ellen really spearheaded this, there were major changes in the strategy that currently exists for polio eradication. It was really something where you couldn't just leave it to those 5 core partners, WHO, UNICEF, CDC, Rotary International, and the Gates Foundation. And I think this is an example of how sometimes organizations like to think they know it all, but what we really need is this outside spur to move things forward. And the role of NGOs and civil society organizations is critical in that. We're now facing what is called the polio transition. It used to be called the polio legacy. But this transition of polio assets is something that I think deserves higher priority in the global health discussions around the world. Dennis King is here from UNICEF, and he's deeply familiar with this, works on this from the UNICEF angle. But I think too often you have other discussions that go on global health that don't reference this transition, even though they're going to be very much affected by it. Because you have a $1 billion a year program, Global Polio Eradication Initiative, that's going away. After the certification of eradication, this program will quickly wind down. And there are 16 focus countries that take up something like 95% of all the assets that GPI uses. Now, I have to say this because Dr. Robert Sanglas is here. Not all of those resources paid for by GPI will be usable and suitable for other purposes, such as routine immunization. They're not all fit for purpose for this. But trying to decide what should stay on and what should not is something that has to be done very carefully. It's got to be focused at the country level, and it has to hear from the non-governmental organizations and civil society that have such a close relationship with communities and know what's really going on around the country. At a meeting of the Transition Independent Monitoring Board in London in May, we heard from the South Sudan delegation. With the eventual closure of GPEI, the possibility of collapse of the the expanded program on the immunization system is imminent. I was told that the cold chain in South Sudan has been funded by UNICEF's polio fund. And again, this is going away. So I think as we come through the next few years, anyone who's active in those 16 focus countries for the programming needs to really be monitoring how this transition of polio assets is going, put pressure on the host government to try to keep those assets that should be retained, and be very much engaged with the donors so they have to play a role in this.
Thank you, John. And now back to you, Ellen. The idea of the bundled approach and the Secretariat model originated with you. From your perspective, could this approach work for other initiatives? And what resources would be required?
Sure. Before I get to that second part, let me expand on a little bit of what Lee said. Before I took on the role in polio, I had been working for 4 years in our Latin America Bureau, and one of my jobs was to work with the Child Survival Grants Program. And so I worked with that program for many years in reviewing NGO proposals that were coming in. And there were many great proposals, but what struck me was that they were still kind of piloting things. They were in small areas. Everybody was working independently, and it was very competitive. And I kept thinking, wouldn't it be great if we could get rid of that competition, get every country to work together towards a single goal, or a little bit broader than that, but in the same general direction. Instead of working competitively, how do we harness networks? And when I came over to the Global Health Bureau and took on the polio eradication project, I had the opportunity to design a program that would do that. The other thing I learned in managing programs and working in Latin America for many years is that governments wanted to work with NGOs, but they didn't want 15 or 20 organizations sitting around the table and overwhelming even their own government counterparts and other partners. So that's where this idea of coming up with a prime organization who would then work with different organizations to bundle proposals. It solved a lot of problems. For USAID, it meant I only had to deal with one organization who would then manage essentially a small grants program. It was a problem solver for governments because the Secretariat director was the person who worked with the governments and the only one they had to interact with. It solved another problem in the fact that we were all working together, so we weren't duplicating training methodologies, we weren't duplicating monitoring evaluation approaches. Everybody was working towards the same thing. Sorry, I'll speak up. And so this is where the genesis of both the Secretariat model and the bundled proposals came from. So when we put out the first RFA, or the World Vision on behalf of the Core Group Polio Project sent out the first RFAs, I went to polio priority countries, which were a lot more back in 1999. And one of the requirements was that any of the international NGOs with their local NGO counterparts who wanted to participate all had to come together with a joint proposal. And that proposal had to be approved in advance by governments and the other development partners that would lay out where the project was going to work, what it was going to do, and everybody had to be on board, and they had to have letters of support before we would even consider giving the money to them. And so there was a lot of upfront work to make sure that these coalitions and the approach and the expectations were clear before the money went. And I think investing that time at the beginning made a big difference in getting the buy-in of the countries and the partners. So we had good set expectations. The other good thing about this project is that we envisioned a very small team in the US. Many of you may not know it, but this is an entirely virtual team. And so USAID doesn't pay for any overhead costs for maintaining an office or any of those costs of being in a central location. Everybody has worked virtually since 1999 with representation on the US side from many different NGO partners who, again, all take their hats off and work for the Coordinated Polio Project. So there's a small team that's US-based, small secretariats. The program globally averages somewhere around 15 million a year. And we reach, Frank can tell me how many beneficiaries if you go up to age 15, which includes all our community-based surveillance work, plus all the work to mobile and migrant populations, hard-to-reach populations. The midterm evaluation that was done in the previous project, Henry Perry's analysis showed that the project cost approximately 17 cents a beneficiary. And so this is extraordinary. When you're talking about hard-to-reach populations and increasing reach and immunization coverage and disease surveillance. And so to me, this model is hugely important. And if we can replicate the model for other health interventions, I think it would be cost-effective and a really collaborative way of working together and harnessing the power of community organizations in many of our key priority countries, especially the most fragile ones. Thank you.
Thank you. Okay, we're trying to leave some time for Q&A from the audience, so we're gonna step it up a little bit. So just in time for you, Lee, you've been involved in the design and launch of several secretariats in different countries. What were the implementation challenges?
Okay, thanks, and I will stand up again. And this goes to, I think, hopefully the reason a lot of people are here today in this room. A lot of you are working on other things, not polio, and you're interested in how this could be used for other interventions, other initiatives, and how you might set that up. And I have been involved in setting this up various times over the years in different countries, first time in 1999 in Angola. And the very first challenge is just to get the NGOs to work together. As my old boss, David Newberry, used to say, it's like herding cats. Just to get a group of NGOs around the table and agree not to compete. When this RFA came out initially, I was working for CRS. I got involved because I was putting in the CRS proposal. And then Ellen Ogden said, well, we'd like it better if you guys agree to work together, so I don't have to choose amongst all these different good proposals. So we worked together with Save the Children, CRS, CARE at the time, I think in Angola, and maybe there were one or two others, I can't even remember now. Got ourselves to agree. It was kind of a coalition of the willing, geographically situated, right? We needed people who were willing and able to work geographically in the places where we were working, and they were essentially all working in child survival at the time. So they had that kind of child survival experience. The next then challenge was to convince GPI partners to recognize that we weren't a threat to them. We weren't trying to take the money, we weren't trying to take over the program, we weren't trying to detract, but we were just going to add on. So we had meetings with mostly UNICEF, WHO, in some countries there was CDC present, of course Rotary International, later Gates Foundation joined the coalition. So we had to convince that group that we were there to add something and that NGOs really did have something to contribute to this. And over the years what I've noticed is there's always been a lot of resistance initially, but I can't think of a single instance in a single country where those colleagues that we've worked with over the years from these other agencies aren't glad that they let us join in that effort. I think they've always been happy afterwards to see what NGOs can contribute to that. And then you had to convince the governments, because they might know UNICEF, they might know WHO, they might know Save the Children. But CORE, is this a new NGO? Well, what is that? So we had to explain to them what it was. That it's a coalition working together, and they have something to contribute to this. So, as I say, herding cats, just getting all of these different groups together. But I think it's well worth the effort. Over the years, we've really, I think, made it work and been able to contribute. Thanks.
Okay, John, what concerns do you have about the idea of adopting the Secretariat model to other health issues? Do you see limitations or areas you think need greater consideration?
Actually, I think there's a big difference between a lot of global health programs and the way that polio has operated. The Global Polio Eradication Initiative is very vertical. It's very much controlled out of Geneva, the 5 partners with input from others, as I was saying earlier. And that's not true for routine immunization. It's not true for so many of the other initiatives out there. I talked to the Japanese ambassador in Geneva, who's the new co-chair of the Polio Partners Group, and she, about the polio transition. She said, the problem is, what is it a transition to? What are we transitioning to? Because some want it to be used for routine immunization to take advantage of whatever assets are appropriate for that purpose. Others would put it under the rubric of global health security. Others will tell you that surveillance is the most important. And there was a midterm review of the Measles and Rubella Initiative chaired by Dr. Walt Ornstein that very much hammered home the importance of disease surveillance. And then the new Director General of the World Health Organization thinks that and espouses the idea that universal health coverage is fundamental as the basis for all other interventions. So that the tricky part of this, to use the Secretariat model in future disease programs or future global health efforts, is how do you end up having a unity that will allow this Secretariat model to work when you have so many different pieces out there, so many different funders, so many different visions of what the future should be and what the importance of different efforts are. And without that unity that we had in the Global Polio Eradication Initiative, I think it may be more difficult.
Okay, moving on to Feely. What are the positive aspects of implementing the Secretariat model?
Well, the model managed to reach, large geographical coverage and address mostly hard-to-reach areas, pastoralist areas, insafe areas, using the same goal, the same strategy, the same objective, and the same strategy. So this is one of the positive I see in the implementation area. The other one is representing many NGOs in Interagency Coordination Committee, that is ICC, and representing in policy-making meetings, and that is also another area where many NGOs in one person. That is another area, and also representing international forums like TAG, technical advisory groups in Polio, North of Africans, and others. This is representing is also another positive areas where there are so many different NGOs cannot get that position, but altogether that is as a chance to have represented in different forums. And also the other issue is avoiding duplication effort among partners. They don't want it, as already mentioned, that it is avoiding duplication of efforts whenever you work it. Divided the places, the districts, and no one is replacing another one. And the other one is attract donors. As I mentioned earlier, it was attract donors to get more funds, and still we are expecting more funds from others. And the other one is also enhancing the capacity of the partners' staffs, and also the frontline health workers and the community health workers. So this is also where for one organization to organize one training, it makes very difficult. But for many organizations, we organize the training, and that is also contributed to capacitate the staffs of the partners. And the other one is creating cross learning among Secretariat partners. This is also a very good platform to learn from one to another. Previously or in other places, maybe the work of World Vision is not clear for Save the Children, and Save the Children doesn't know what IRS is doing. But in these terms, they can learn from one to another, and the implementation, the approach, and they share the experiences that they have, and that is the platform created this important things.
Okay, and then Ellen, you get the last word. what steps can we and others take to increase the chances that appropriate tools and approaches from core group polio project are used in other health programs?
Well, first of all, thanks for being here. This is step number one, is dissemination. We didn't think too many people really understood the Secretariat model and what its potential is. And so we're counting on you to bring some of those messages back to your own organizations about what the opportunities are. I think there are things at the global level. Right now, the community piece of polio transition is not well articulated. We hear a lot more about what each of the UN organizations is doing or what the countries are doing in transition planning. But there's not really any specific discussion about how to transition the community platforms that have been developed. And I think that needs more attention, and it's something that will continue to be raised in the polio partners groups and others, is how to make sure that that's more systematic as we go through this global transition discussion. But I think there's more applicability. So I think within the NGO community, it's taking advantage of opportunities to develop Secretariat models. I know USAID runs a child survival program where there's a component that allows for proposals, bundled proposals. But I don't know that we've ever received any. And so part of it is how do NGOs themselves get organized and put forward proposals to work in critical areas, whether it's malaria or newborn health or TB or whatever. And bundle that and present it to donors as a bundle proposal, and convincing donors that may not be familiar with the model how to go. I think other programs need to understand better the potential here and the cost effectiveness of working through Secretariat. I think the Gavi CSO platform in particular could probably learn a lot from how the polio NGOs are organized. And then within USAID and other donors, I think we need to find ways to institutionalize this model a little bit more throughout our programs. I mean, one thing that would please me greatly is have little toilets in every country with a set of child survival interventions, all working together. But to do that, it's sort of a major rethink for us, and whether there is interest, the NGOs, as I said, if you're not expressing interest in something like this, the donors may not push back on this or provide opportunities for that. So I think we're hoping this is the start of a dialogue on how can we rethink our engagement for these broader health initiatives, whether it's universal coverage or reaching the fifth child. I think there's tremendous potential in how we organize ourselves at moderate cost to get into some of these areas with a set of interventions. Thank you.
Thanks, Ellen. So we have about 10 minutes for Q&A, and we're going to need people to speak into a microphone. Is that correct? Do we have someone who can run the microphone around, or should we just put it in one place? Okay, so Dennis, can you identify yourself and your organization?
I'm Dennis King, and I'm a Polio Transition Manager at UNICEF. That's a brand new title. And I didn't really understand the scope of this meeting until I arrived. And so I'm really, really glad to be here and hear this discussion. I have two questions. I don't know who would be best to address it to, but has a mapping been done by CORE of those fragile or otherwise countries in need who are most optimally conditioned or situated in NGOs that are likely candidates for this Secretariat model? As we know, some countries are very resistant to the creation of indigenous NGOs, and some it's a flourishing. So the first question is, in sharing this to a broader global audience, has a mapping been done of countries that are likely to be a good applicants? And the second question is, I think you know, Ellen and colleagues, that in Tokyo in December, there's going to be a UHC summit, if you will. Our executive director from UNICEF is going to attend, and the Prime Minister of Japan, so a number of other global leaders to talk about really being more clear, what do we mean by UHC? And my question is CORE going to be participating? It seems to me that model would be a really appropriate one for that discussion. Thank you.
Okay, I think I'll try to take that. The first question you asked, I might have had to just hand the mic to Lisa Hilmy, who's sitting next to you. In terms of mapping, we within the current project have very good mapping of the assets of all the places where we are working, which is roughly 7 countries. But in terms of the broader coalition of CORE, roughly 50, mostly American PDOs, NGOs, all the big names that you would think of, CARE, World Vision, Save the Children, etc. The CORE Inc., as we sometimes call it, the CORE, larger CORE group does have a mapping of where all of those different NGOs are working correctly, so online, yes. Okay, in the different countries. So that could be a good asset for that. And then to the second question, invite us, and we will come, okay? Thank you.
Thank you very much. My name is Falaki Olainka, and I work with the Maternal Child Survivor Program, which is USAID's flagship program for ending maternal child death. And I'm the immunization team lead there. Now, this has been really wonderful perspectives, and the more I think about it, I would like to ask, if you were to do this again, what would you do differently? If you were going to roll out this model again, what is that you would do differently? Thank you.
That's a good question. I'm thinking back because when I first envisioned this and we started to float it within the global program, I got a lot of pushback from UN agencies to the point where one of the spearheading partners wanted to report me to Congress for malfeasance because they thought this was not an appropriate use of polio funding and that the NGO community was not able to perform up to the standards of some of the other organizations. You're tree-hugging do-gooders, lots of well-intentions, but questionable whether we can perform at the levels that are going to be expected. And I think that today, we don't have to deal with that so much. I think there's tremendous amount of literature dissemination. We're trying to capture the lessons learned, the data that's available to show that that's just not the case. And so preparing the ground with some of our other partners about what the capacity is and the ability of NGOs to work at very high technical levels, I think would be one thing I could do better now because we have the data.
Good morning, and really glad to see a mixed crowd here. I'll briefly answer or address, and then I have a question also. So CORE Group actually has grown. We're celebrating 20 years now, and we're over 85 organizations, academic institutions, and individuals, and we will be taking international membership soon. So we're really expanding on that platform of collaboration. I'll give you a quick example. Ebola in DRC recently, outbreak. I had a call from UNICEF and WHO, risk communication folks, and said, who are your NGOs working in DRC? We need to mobilize over Ebola. Within a day, we had all their contacts. We had 15 organizations connected with these guys so we could have a more thorough response on the communication for Ebola that was happening with CAR as well for cross-border activity as well as DRC. So that model of working together, superb. My question, so I was this week earlier, I was at the UN General Assembly. I see some of my colleagues, Aaron from Academy of Pediatrics, was also there and the discussion about universal health care. So, we did have some conversations with Dr. Tedros as well as the private sector, DevEx, and some others. And there was a lot of discussion about the private sector, about the governments and country level, about the UN, but the voice that kept sort of getting last was civil society and academic institutions. So I'm really excited that this dialogue here, as Ellen mentioned, Henry Perry's study involved academic data and research and also the civil society and community piece. My question is, how do we get from the high level perspective to incorporate, such as the corporate polio process did, by involving civil society, governments, UN, working together on the country level in a more cohesive, non-competitive manner? Thank you.
Does anyone want to take this? And then we'll have one more question over here.
And this may kind of tie into one of the other questions as well. You know, one of the things that we did when we started this project out in each of the different countries is we had a workshop, something like this, and we invited all of the partners that were interested. So there was an open dialogue, and everybody got a chance to sort of hear what it was we had in mind, and raise their concerns. And there were plenty of concerns, but it was kind of open and transparent, so everybody had a chance. And I think that was at each country level, and it's probably important that we're doing some of these now at I want to call it the US level or the global level, where you get partners around the table and they can ask those tough questions, and you do it openly and transparently, and hopefully you improve and learn from that process. And if we can, out of that, create secretariats, or maybe use sort of the nexus of the secretariats that already exist in some of these countries to move on to other initiatives, as say our colleague in Ethiopia has done. I think that would be great.
Great. Hi, I'm Judith McCord. I'm the director of Every Creamy Scale at Project Concern International. And thank you. This has just been so fascinating. I've been working for quite a while in this business, and have been watching a number of really interesting global health issues move in this realm of global secretariats. Malaria, rollback malaria is one. We now have Every Woman, Every Child, and a lot of really exciting catalytic work happening there. And I'm very interested to hear from you about your metrics and how you have measured the catalytic effect of this secretariat model. Because, as you know, as I've just said, we have a number of really interesting global networks in the world of maternal and newborn health, and we're really trying to get our hands around that catalytic effect. What does that look like globally? It's a little bit easier to see, but then how it translates to the national level is a very different conversation. And of course, maternal and newborn health, in broad terms, is far more complex than a single intervention of polio eradication. So I'm just interested to hear a bit more about your metrics and that catalytic effect. Thank you so much.
A couple of the things we've done is nearly every 2 years over the life of this project, we've hired a team of outside consultants, usually one central consultant to look at the whole project, and then individual consultants for each country where we're working. So those reports, those evaluation studies and reports are available on our website. And currently, we're trying something else out. So Chris Morry is going to be our next speaker. It was something, an idea we got from him to put out an RFP for journal articles. So we've got a lot of different journal articles that have been written, peer-reviewed journal articles over the years, some looking in particular at the Secretariat model, others looking at other aspects of the project. And right now we're working on roughly 10, which our evaluation team are coordinating. I think those are a couple of the main ones. Judy Ann McNulty, some of you may know her, is just wrapping up our most recent evaluation in seven countries of the project. So that report will hopefully be ready within a month or two. Thank you.
Just quickly, we try to instill a pretty strong monitoring and evaluation framework within the project that all the NGOs are contributing to in a country, so it's not looked at by individual NGO, it's collected across the project areas. But just some notable achievements. Roma Solomon is here from India, can tell you when we started in Western Uttar Pradesh, routine immunization coverage was 5%. And now it's close to 60–70%. Newborn birth dose has climbed hugely as a result of the child tracking activities. All of our projects, I think most of our projects, are working in community-based surveillance. And Philly can talk to the fact that many of the AFP cases in pastoralist areas are being identified at the community level. And they're looking not just at AFP surveillance, but measles and tetanus as well. And so when you dig down into what's actually happening in terms of changes in interventions, coverage levels, and surveillance reporting, reduction of refusals, the engagement of local leaders in the discussions to help solve problems. I think there's tremendous amount of data available that we're hoping to get out in peer-reviewed journals. Some of it's already out there, testimonials and other ways of sharing that information. But there's quite a wealth of data out there.
Maybe one comment to my understanding that the global level consortium is different from this one. That one is high level. They discuss the programmatic issues and other issues, but this one is different from that one because this one is actual implementation and very difficult to bring together different organizations to implement the same strategy, the same objective, the same activity. So that is a little bit different from the higher level and this one is more complex.
Okay, so great comments, great questions.
This panel is going to take a little deeper look now. So we kind of really went across the kind of broad global strokes of what is the model, how does it fit at that global level. And now, because we have the core group Polio project country directors here, this gives us an opportunity to look more closely at how these programs are working on the ground. However, not to let these guys completely off the hook, we also want somebody from outside of the core Polio project to also be able to reflect and comment on some of the things that they're discussing and questions as we go through. So we have on the panel here Roma Solomon, who is the director for India for the Polio project. Anthony Kasanga, who helped a lot in our group in South Sudan. Sam Usman from Nigeria. And Ahmed Arali, sorry I can't roll the R's quite properly, but who's from Kenya, the Nairobi-based, but Kenya, Somalia. And Craig Burgess, who's the JSI Senior Technical Officer in the Immunization Center. Yeah. Okay, great. So that's our panel. We're going to follow the same process that we did before. So I've got a series of questions. Hopefully everyone will keep their responses full and complete, but short at the same time. Because everybody's waiting now for lunch. So let's start with Roma. So Roma, you've been involved with CORE for quite some time, shall we say. What would you say are the most effective tools and approaches that have been developed or used by CORE group Polio?
Thank you, Chris. We went in with a lot of approaches and tools, and we have to do that if you have a budget or line item, interventions all laid out. But the first thing we had to do was to throw out all these, everything that we had planned, because we, as the government was also surprised, we were thrown into the deep end of the program and asked to assist the government in a program that brought so much of resistance, physical resistance. We were stoned, we were, poured hot oil on, and they used to hide their children. Whole villages used to empty, and it shocked the government and us. I mean, what were we there for? We thought we were giving them a very good intervention. We were looking after their children. We were stopping their children from being crippled with polio. And suddenly we realized that our mandate was not so simple. We had to turn this government program into a people's program. And that happened because the resistance happened because earlier the government was giving polio drops in booths, and women used to line up every day to get those polio drops for their children. But then we couldn't catch the entire population, so the government in its wisdom decided to go house to house. And that's where the suspicion started and the rumors began. Why were they bringing only polio drops? 2 drops meant 2 children, maybe. And we had a very coercive family planning program, and there were not many bonds between the government and the underserved populations. So we were suddenly stuck with this, and by that time, you see, we as a PBO consortium, and our PBOs, we had World Vision, we had CARE, we had ADRA, we had PCI, we had CCF. So we all thought we had the whole technical know-how and we knew all the tools and approaches that they were ever discovered. And suddenly we had to just unburden ourselves, throw the baggage away. We were no longer doctors, we were no longer public health specialists. We had to listen to the communities. They made us listen to them. And when we listened to them and we heard their tales and their stories, so we had to then learn new approaches. We had to be flexible. We had to leave some of the budgeted line items back there and come up with new things. We also had to strike a balance between the government program, the technical program, and what the communities wanted. They said, why only polio? So we said, okay. So we requested the governments to set up health camps. And then we realized our own potential as PBO consortiums, working with the CBOs as well. We realized that our potential was that we could put in mobilizers. We could put in people from the same communities as the ones that had resisted, train them, skill build them, and give them very simple indigenous tools. Not cost-intensive tools in which they had to go in for training and things like that. So suddenly, these kind of things, and we started breaking ground with both the government and the communities. The keywords were listening, the keywords were collecting simple data, which these mobilizers could collect, could then read, could use, and put back into the program. This data was also shared with the government and the WHO. And then, so this became a very valid program for us. There were questions that, how many, what monitoring and evaluation was going on. And every year we sort of made this better and better, depending on what we were giving and what the communities wanted. The other thing, apart from the mobilizers, we used a lot of influencers. Every community, every village, every city has its people who people listen to. These range from Muslim religious leaders, mainly Muslim leaders, people who wrote fatwas and then ran away, and we had to chase them because we had to get the unfatwa done. We had to, we had to do ration dealers, twist people's arms a bit, not use the police and the army, but like this, harder methods of coercion. We put in health camps. We also, then we realized the men were not listening and men were the decision makers. If they told their wives don't allow the polio team in, there was no way the wife was going to open the door for us. So we decided to, we thought about it and we said the only place a man is quiet, apart from the evening where he gets noisier, the only place, I'm sorry, I shouldn't sound sexist, but the only place he has to keep quiet is in a barber's chair. So we are now using barbers as well, who, when they are shaving the man or cutting his hair, they start talking about immunization. Have you immunized your child? Not just polio. This is routine immunization as well. From the beginning, we have worked with routine immunization because we wanted to keep the population immunity high and get people to come to the immunization sessions themselves, not sort of thrust on them. So basically is that, and then the other thing was flexibility of our innovations, of our strategies. the virus was very quick for us. It was like quicksilver, it ran from one place to another and we had to chase it. And then we had to immediately, unadapt our strategy, adapt new ones. So basically those were the strategies and tools that we were.
Thank you, Roma. It's a very concise and clear, concise especially for India. Anthony, moving to obviously a very different context and a very complex and difficult situation in South Sudan. Can you say something about the use and purpose of independent campaign monitoring?
I think I want to start by saying, when you talk of independent campaign monitoring, we're talking about data. And the data you must have a quality data. That has been something that has been lacking before core group started in South Sudan. So there has been, no independence of the polio campaign monitoring. The same players at the same referees. So you cannot be able to be a player and at the same time you're a judge. So when we started, what happened was World Health Organization, the government, UNICEF saw an opportunity in core group being an independent civil society to be able to give credible data that is quality, that is reliable, and that can be more credible to inform subsequent rounds of polio immunization campaign. So in 2013, if my conscience is right, they approached USA through Ellen in Nairobi when we were for Horn of Africa Technical Advisory Group. And they went and pleading to Ellen saying, please, we want core group to take over the post-campaign independent monitoring for polio in the entire country. And by then, we were just like Secretariat of 3 or 4 people. And we're talking a country of over 600 square kilometers. So that was difficult. But they understood, our strength. Our strength is the partnership and the model that we have. Within small secretariat, we can reach the imaginable. We can reach the entire country within no second. So what happened in 2014, we took over and became the lead in conducting independent campaign monitoring through the support of USA. The most important thing that we looked into is produce independent quality data that can inform the subsequent polio campaign rounds. So what we did was we conducted this round, the collection of data, we analyzed data to kind of inform WHO, the Ministry of Health, UNICEF, which places have actually had quality vaccination, which places have not been reached by vaccination, where there are refusals. If I talk about refusal, people who are refusing to kind of accept the vaccine, we look into social mobilization, it's kind of a range of things. Basically to inform, okay, if there's refusal, UNICEF actually use this data to inform their communication plan. And basically WHO use that to improve their operation. Then the other thing that actually we instilled in the independent campaign monitoring for polio is the accountability. Because what is happening is you must be accountable to the donor, you must be accountable to the country, and you must be accountable to the people. That means okay, you're given money, have you used this money to reach the children? You must be accountable to the community by ensuring that you take vaccines and be able to reach that last child in the hard-to-reach areas. And that is what we did. We use this quality data to inform the programming in South Sudan. Thank you.
I'm going to skip right now to you, Sam. for a question, and perhaps we'll come back if we get a chance. And so basically to talk a bit to the strategies that you've developed, particularly working in the security challenged areas that many of us are aware of in Nigeria.
Thank you, Chris. I think I will start by saying that Frank, our director, and myself went to visit Kano State, which is in northwest Nigeria, and one of the most populous states in Nigeria, to see the incident manager who happens to manage the program's polio eradication system. And he said, "Hey Frank, have you ever asked me why we asked you to come and work in our state?" And Frank said, "No, why?" He said, "Because we wanted to take you to the most difficult places." Frank said, "Really?" I said, "Yes, we wanted you to do the dirty job." So I will start by saying that CORE in Nigeria is working in the most insecure and dangerous parts of the country. And that is not a coincidence. That is not a mistake, nor is it a coincidence. Because when we started in 2014, that was at the height of Boko Haram insurgency in Nigeria. And so in Borno State, where Boko Haram insurgency was basically the epicenter, no partner wanted to work there. Community volunteers were unavailable, the government system was falling apart, and people were looking for who to go and mobilize those communities to ensure that children were immunized. And so how did we do it? The first thing was to do a very quick security assessment, working with the local security agencies to understand where the insurgents were based. And after getting that information, the next most important thing was to build trust. Because in those areas, trust is a big issue. Here you have people who say Western education is dangerous, and you want them to immunize their children. So that is like a paradox. So the first thing we did was to build trust. How did we accomplish that? We accomplished that by firstly getting the key people in communities to buy into what we wanted to do. And how do we do that? We ensured that we recruited volunteers, community health workers from those locations who understood the local language, understood the local challenges, and would be allowed to enter those households. And I can tell you that people trust women. People believe in women. And so we recruited the volunteers, the community health workers, from the women. We ensured that those women were married, so they could understand the pains of childbirth. They were trusted, and people would allow them to go into their households. So we engaged them and we trained them. And importantly, we trained them on not just on polio, but on polio plus. So if you go into the household, they're not just talking about, hey, allow your child to immunize. They're talking about the importance of using locally available food to prepare nutrient-dense diets that will make their children healthy. We're educating them about the importance of exclusive breastfeeding. So the messaging was very important. Firstly, we did a security assessment. Secondly, we built trust. Thirdly, we ensured that the messaging was what would improve the well-being of the children and not just polio. Second thing is, we realized that in my part of the world, the stomach is the fastest way to pronounce out. So what we did, during the fasting, we did what is called iftar. For those of you, for the Muslims among us, you know that iftar is the breaking of fast. So what we did was, we engaged with the mullahs. We said, look, during the breaking of fast, we want to support areas where we have huge vaccine rejection. So we went to the mullahs, we said, we want to provide food immediately after the prayer for breaking of fast. But we want you to help us to educate the male heads of households where there was vaccine rejection. He said, hey, that's fine. If you have the money, so we have the money. It's not too much. It's just to get some bean cakes, some pap, and you follow for the heads of households to break the fast. So during the fasting period, at the break of fast in the evening, after the prayers, the mother says a word or two about the importance of allowing the volunteers to go into their households to educate their wives and mothers on the importance of vaccine. And we did it, and amazingly, almost every household, about 90% of households where they rejected vaccines, allowed vaccinators to go in. Thirdly, and very importantly, is the issue of routine immunization. One of the biggest issues in our part of the country is card retention. most in those security compromised areas, you have families that do not have the routine immunization card. And so it is difficult for you to assess how much vaccine the child has had. So what we did was, working with our because CORE believes a lot in collaboration. The India program has a lot of competency in communication. So we worked with them and we developed routine immunization card holders that will enable mothers and caregivers to be able to keep their routine immunization card safe. And so that way we were able to increase card retention. Another important thing we did was the messaging. People were tired of hearing only polio, polio, polio. What we did was we included messaging on exclusive breastfeeding, messaging on water sanitation and hygiene, and even, for instance, in India, we developed soap strips, simple soap strip that has detergent in it. So when you remove the soap strip, put it in water, and you squeeze your hands, and it becomes detergent. Because there's a link between poor sanitation and polio transmission. So that was very innovative, and in those areas where we use those soap strips, there was increase in immunization uptake. Importantly as well, in the northeast part of the country, malnutrition is a big issue. So what did we do? We trained mothers and caregivers on how to prepare nutrient-dense diet using local food. Because we realized that the pumping laws that is provided by the US government is very useful. But the average time it takes for you to import pumping laws in my country is about 6 months. And all over the northeast, most hospitals have been destroyed. A lot of markets are not functional. People cannot go to the farm. So we quickly trained mothers and caregivers to use locally available food to prepare nutrient-dense diet, and we were able to ensure that malnutrition was addressed, and that led to also increase in uptake of vaccination. Thank you.
Thank you, sir. Ahmed, Kenya and Somalia. Can you say a little bit about the kinds of strategies that you've been using to reach mobile, migrant, and hard-to-reach populations?
Thank you. I think for Kenya and Somalia, Core Group Polio Project works in 5 counties in Kenya, and that 5 counties are along the border of Kenya, Somalia, Ethiopia, South Sudan, and mostly those are called arid and semi-arid lands, if you maybe know of Kenya. On Somalia, we work on the other side of the border, 6 districts. So when my brother here is talking about Boko Haram, us on the other side we talk of Al-Shabaab. Yeah. So I think in those border areas, especially those counties that are arid and semi-arid lands, the most important population there is the mobile population, and that is the nomadic pastoralist. And many times, these are populations that are, we say, out of the conventional, healthcare of these countries. As you know, they transit borders, they have no borders, they are mostly related. Kenya, Somalia, Ethiopia, Kenya, all that, these are relatives, and they move across borders. And many times, these are insecure areas, either terrorism, either cattle rustling or tribal clashes, and many NGOs, really there's good guidelines, will say don't go 60 kilometers or 80 kilometers to the border. So, and that's the much these areas are marginalized. So what Core Group does is we work with this mobile population, especially pastoralists. And what we do is we map the migratory routes, and so we offer them services. And when in other places we talk of polio only, as we support the Ministry of Health, we do outreaches to these nomads. And when we are doing these outreaches, we are not only giving polio. So we support in giving also other vaccines. So, and this mobile population, it means you have to track them always. The other thing we do is cross-border health initiative. And this one was something that Core Group developed. And currently we are working with WHO, UNICEF. Now we're going to do bigger forums of a joint cross-border collaboration between these countries. And what we do is we have mapped the transit points. And in these transit points, we have transit vaccination posts. We work with the immigration department, we work with the local authorities at the borders, so that we know where they cross, and that is where we have these immunizations. Thank you.
Thank you very much. So now to given your history with routine immunization as well as knowledge of polio and whatnot, can you say something about your reaction to these approaches, to what you've heard both here and this morning, and reflect a bit on, is this something that you think could be useful, routine immunization, measles elimination, or other health initiatives? And basically, because we're combining things here, some of your concerns, if you have them, and senses of optimism or opportunity.
Thanks, Chris, and thank you very much to fellow panel members and the previous panel as well. I've worked alongside CORE since 2002. And what gets me excited about CORE and the principles basically is that is the customer focused. I'm kind of using a business model because someone else said it's a business we're in. Customer focused in terms of driving, in my opinion, acting as a counterweight to some of the top-down approaches coming from, it was mentioned today, from Geneva, but also at Seattle and other places as well. So customer focused, I would say, is very, very important. That's what gets me excited most about CORE. And I think partnership, as you mentioned, in terms of leveraging resources, knowledge, capacity, and this issue of kind of cooperation, not competition, has been emphasized this morning as well. I think it's very important, specifically at the community level. What are the added benefits of CSOs and the CORE group? That, from my perspective and what I've heard this morning, is really, I heard the word trust. And trust does not come easily, and is easily broken in many different ways. Many of us have worked in different areas where trust in government systems is completely broken down. So the kind of the core elements of trust are very important to help break down the social barriers to accessing health interventions and vaccines, representation, also in urban and fragile settings as well. Very, very important. And I think trying to understand communities and representing communities, specifically you mentioned nomads, ethnic minorities, in terms of understanding them better, helps programs be designed more appropriately and with more acceptability as well. I think where CORE perhaps struggles, and civil society in general struggles, is this issue of accountability. Not accountability of civil society, but holding donors, holding some secretariats, and some governments to account as well. So civil society can sometimes be very uncivil, and is sometimes pushed to the margins, as we've heard this morning. So I would get very excited by looking at different ways and models of representation of civil society, not meaning NGOs, but really meaning civil society, those groups that represent women, represent vulnerable communities, to give them a voice more powerfully. More specifically, you asked about what might work or be translated, and just in a bit more kind of thinking about it with colleagues in my team, things like detailed micro-planning and mapping out, household listing, social mobilization, defaulter tracing, case detection, communication for development, and even just representation of women's groups can all be, in our opinion, perhaps applied to other interventions beyond routine immunization, which includes newborn health, ANC, nutrition, a whole range of other health interventions as well. So there's a lot of synergies. So what I've said, I'm an optimist, and what I've said is quite kind of very positive. So routine immunization, for example, can learn from polio, and there's a but, and unfortunately there's always a but. And I think we have to kind of all, as a community, a wider community, take these buts to kind of into mind. And one is that polio has managed to bypass national systems for a long time as a program and set up parallel reporting, financing, and kind of planning structures. And as polio shifts, we need to kind of think very carefully about how resources or assets that have been described this morning can possibly be adapted to the decreasing resources and the need to become a lot more country-driven and community-orientated in terms of planning and financing at community levels as well. The other issue that came to mind was really the SIA, the Supplementary Immunization Campaign, armies of volunteers and community health workers
are great for campaigns, but then they kind of disappear, or some of them disappear. How can we mobilize all that energy and all those assets on a more regular, routine, systematic basis for something like routine immunization? And I want to kind of just mention another kind of cultural dimension of disease control. And I would say, obviously, polio is very focused on a disease control effort. But another way of controlling diseases is, of course, through primary healthcare and universal healthcare coverage. Many countries, as we know, are entering into UHC. There's another way of addressing disease control on a more sustainable footing. And sometimes there's a kind of parallel, I call them parallel universes. You can go to a meeting on measles or polio, you go to a meeting on UHC. And sometimes the two groups never meet, they never connect, there's no connection. And I just think, why is there no connection? I think there's no connection because sometimes we can blame it on the funders, sometimes we can blame it on the way in which our careers are structured. There's a whole load of blame. And I want to get away from the blame and encourage us all to think about how can we come together under one common goal where we don't lose many of the assets that have been built up under core, and they can be adapted and used for many other purposes. And it might be more locally owned and more in tune with not becoming, I heard this morning, I'm a polio person. Another person said, I'm a measles person. We're not measles or polio people. We're people, we're communities. And I think the communities that you represent and you've talked about are people. We're stuck in a medicalized model that is 40 years out of date. I think we're going to be a lot more community orientated if we're going to look forward. So my last point is just about some of the concerns and prerequisites, and I'll be quick, are obviously the cost and sustainability. Polio obviously is 20 years kind of overdue in its deadline. My father had polio as a kid, and no one wants to see the end of polio more than myself and my father. We're all bought into it, but it's 100 times over budget. And there's some big thinking got to happen between now and when we actually transition assets. The budget's going to decrease. So cost and sustainability. We're moving into cost and sustainability. We need to think as a core group, how are those issues going to be addressed at domestic level? How are some of the costs going to be covered by domestic budgets within a UHC primary healthcare kind of way of thinking about things? And the other thing is, all these assets are not assets, they're people being invested in. Are community health workers who often aren't paid for 6 months on end or a year on end. They're working for free. How do we stimulate that sense of community ownership to be used for other interventions as well? I think there's ways of doing it, and I think there's ways of keeping up the motivation, but we've grown up with a whole generation of perhaps health workers who are used to incentives and used to parallel incentives beyond the financial salaries that they get from the ministries, and that's the reality. The other concern I have is, I guess, with not just US Congress, but my own country, the UK, and bilateral donors in the West, and their attitude. Their attitude towards short-term political thinking and buying in what looks good for the voters, and that's obvious. I'm not trying to be naive. And the other issue is attribution versus contribution. Are we attributing and wanting actually dime for dime, wanting to know where every buck goes, or are we willing to take a risk and look at contribution, and look at blending in and working with a lot more, thinking about domestic resources in the countries that core work in? And I would just want to kind of push one or two other things, and one is encourage us all to think a bit more the linkages with other interventions that are happening, such as UHC 2030. So there's a civil society group that many of us in the room, I think, are engaging with. I would encourage us all to kind of look towards that group as we move forward. So I think CORE have a huge amount of experience and assets to share with that group. And also things like the global financing facilities, particularly for maternal neonatal child health. There's a kind of thriving, emerging civil society group engaged with that group as well. It might not have occurred to some because we're focused on polio, but I would encourage us all to kind of think broadly and think about engaging those. And I think this reorientation at country level of kind of where things might go needs to also happen at global level. And I would encourage those that are engaged with the IMB and the transition of assets of polio to really think about inviting, getting out of the echo chamber. And I say it's an echo chamber because people are talking sometimes to like-minded folk. We need to challenge ourselves all the time to get beyond our comfort zone and think about talking to others who are thinking a bit more broadly, and that may well actually benefit in terms of resource mobilization. Well, thank you very much.
Thank you, Greg. Do we have time for a few questions?
I'm Allison, and then Foster. I'm with InterHealth International. One question I'd like, if we could maybe address in the small groups, is communication and data collection. Because we're talking about cross borders and very difficult situations, and in the earlier discussions we talked about the importance of tracking and this, and all of us who are in development are working a lot with mobile apps and communication and trying to integrate all those systems and find ways so that they're not siloed themselves. And we need this support in these community areas, and particularly in these fragile states. So we haven't had a chance to talk about that, but that's important both in coordination and also data collection in the need. Thank you.
As I've been hearing this discussion, including our meeting group earlier, there seems to be a struggle as to what is the shared vision for the future after polio ends. And I have to say, I spent the last 4 days in New York in a lot of global health meetings going on in the margins of the UN General Assembly. I think the only viable concept that will get global support is universal health coverage. It gets support from the Director General of the World Health Organization. It's one of the targets under SDG 3, the health SDG, and it encompasses everything we've been talking about. It encompasses routine immunization and measles elimination, all of the global vaccine action plan goals, and maternal and child health, et cetera, et cetera. So now I have to say, in terms of funding, there's a bit of maybe a bit of a difficulty within the U.S. government in terms of in terms of supporting this, because some could say it smacks of Obamacare, and that would not go well with the current administration. So, but you have Dr. Tedros, the Director General of WHO, has said universal health coverage and global health security, which is supported by the current administration, are two sides of the same coin. So my question is, since I really haven't worked with the Secretariat model in the country, can the Secretariat model encompass this possibly by having subgroups within it, that you have kind of a broad coalition and collaboration among NGOs supporting the broad goal of universal health coverage, which I have to think every community would support, and at the same time have different subgroups within that who may be supporting the maternal and child health efforts or measles elimination or others.
I'll be speaking from the last question. I think across all of the CGPP countries, one of the common themes that we understand from ab initio is the fact that the model that we're implementing is for sustainability. Sustainability in the sense that the beneficiaries should buy into it, they should own it, and should understand that it is a means through which they can access broader health services. So it is not a means, an end in itself, but a means to an end. That is, the Secretariat model can be broadened to implement other health interventions that can improve access. So I think that the premise of using community volunteers or community health workers from those communities where they work to train them on not only polio eradication, but importance of antenatal care visits, importance of nutrition, importance of exclusive breastfeeding, importance of water, sanitation, and hygiene is a way of looking at it in terms of universal health coverage. And I will use Nigeria as an example in terms of coordination. We have what we call the Polio Emergency Operations Center, which is working very closely amongst all partners to ensure coordination. And the whole goal is to ensure that every community in our country has this cadre of community health workers that go house to house and raise awareness on not just immunization, but the importance of healthcare. So I think from that premise, one could say that the Secretariat model is aligning with the issue of universal health coverage, especially since it has been proven that the only way you can truly improve universal access is through primary healthcare. And these community health workers are at the forefront of delivering primary healthcare services at the lowest cost possible. Because I think my colleague from India talked about the issue of cost. So the Secretariat model is very, very cost conscious. Then the issue of, I'm going to flip over to the issue of communication and data collection. I think arguably we can say that the polio eradication effort has been able to maximize communication approaches to the fullest. And I'll give a few examples. For instance, in India and Nigeria, many other countries, the community health workers we use at that level are able to communicate in the most basic way to pass the message. I was talking with my colleague in India. For instance, we have different models that enables the volunteers or the community health workers to break the message to the lowest possible level, so that they are able to understand, for instance, the importance of hand washing. And that is why, in terms of communication, the community health workers have this flip book. It's purely pictorial, adult education. There's no too much, writing and all of that. It's just so they demonstrate how to wash your hands, the importance of antenatal care, even how the virus is transmitted, the polio virus is transmitted. It is that basic. And of course, talking about data collection uses the most minimum, the barest tool possible, which again is basically a register, which is done in the local language. For instance, in Nigeria, the registers are in local language. It's not complex. Each community health worker has what we call a land list of households, and she's from that community, so she goes house to house, speaking the local language, asking questions in the local language, and collecting data in the local language. And a tier above that community health worker is a senior to her who has a smartphone, and that smartphone is used for data collection. So data is aggregated with the smartphones and disseminated with the smartphones. And very importantly, in the area of supportive supervision, now it is mandatory that you don't just go to do supportive supervision, you use the smartphone as well, which carries the open data kit for data transmission. And there's a lot of coordination in terms of data collection and quality assurance, just to ensure that data that is collected is also validated. So I don't want to take too much of time, but I think that maybe during the group sessions, we can talk more. But in terms of shared vision, one of the things I want to quickly talk about is the fact that from ab initio, the project was very clear that the vision of this program is not to create a parallel system, but to ensure that it builds into the existing system. And that is why in all the communities where we work, at every level, from the ward level, to the LG level, to the state level, there are coordination platforms. All partners belong to this coordination platform. Let me give you a very quick example. There are districts in Nigeria where CORE works as well alongside with UNICEF. We don't work in the same areas. We have coordination meetings and they say, okay, we are working in A area, you go to B. So I think the coordination in the process is quite strong. Thank you.